Everyone, I'm going to talk to you about acute glomerulonephritis today. Acute glomerulonephritis is an immunological mechanism that is triggered by some kind of inflammation, which leads to proliferation of glomerular tissue, and it can result in damage of the basement membrane, mesangium, or the capillary endothelium. Acute post-streptococcal glomerulonephritis is the archetype or the typical example that we use for acute glomerulonephritis. It's characterized by an abrupt onset of hematuria, wherein there will be RBC casts in the cell, if not just RBCs. Almost 99.9% of the patients will present with hematuria. Then you have cases who have mild proteinuria. It's usually less than 3 grams per deciliter per day. And then there will be reduced GFR. There will be oliguria. There will be salt and water retention in the form of edema. The patient, about 80 to 90% of the patients will present with edema, and about 60 to 80% of the patients will present with hypertension. And this usually follows a secondary viral or bacterial infection. As you know, that it's mostly going to be either in the form of a throat infection or a skin infection, as I will let you know. So the basic pathology or the pathomechanism that happens is that there's glomerular deposition or in situ formation of immune complexes. There's gross appearance, and the kidneys may be enlarged up to 50%. Histopathological changes can include a swelling of the glomerular tufts, infiltration with polymorphonucleosides. Immunofluorescence reveals deposition of the immunoglobulins and complement. Non-infectious causes can be in the form of multisystemic problems like a vasculitis in the form of polyangiitis granulomatosis. That's vaginous granulomatosis is what we used to call it earlier. You can have acute glomerulonephritis in a case who has SLE, like a collagen vascular disease like SLE. In a patient with hypersensitive vasculitis, they also may present with the possibility of having acute glomerulonephritis, cryoglobulinemias, polyarteritis nodosa, Henoch-Schönlein papilla, Goodpasture syndrome. Primary renal disease that are non-infectious and can cause glomerulonephritis can be mesangial-proliferative glomerulonephritis, and Burgess disease, and pure mesangial proliferative glomerulonephritis, and idiopathic RPGN, that's rapidly progressive glomerulonephritis. Okay. Miscellaneous causes are a Guillain-Barré syndrome, irradiation of Wilms tumor or any irradiation at all, diphtheria, pertussis and tetanus vaccine, serum sickness, epidermal growth factor activation, etc. So, but the most important thing when you think about acute glomerulonephritis, especially for exam purposes at this point in time, you want to consider, this is not an emergency topic, so remember now these are going to be focused more on what you need to answer in the exam rather than what you want to bother to see in the casualty. These patients don't generally come to casualty, they are going to walk into your OPD and you will have to evaluate them from there, either on outpatient basis if it is mild or not very stormy, or if the patient is bad, then we will have to see them in the casualty. Okay, and we admit them if need be. A lot of these cases, if mild, can be managed on outpatient basis itself. So, but like I said, the glomerulonephritis, the archetype or the the prototype is usually acute post-streptococcal glomerulonephritis, and even in the exams, that is what is frequently asked as a question. It can come as a 3-mark question, it can come as a 5-mark question, or it can come as a essay, like the 10-mark essay. Okay, for postgraduates, it's a 20-mark essay. Etiology, pathogenesis or pathomechanism, clinical features, and management. Okay, so in the etiology if they ask acute glomerulonephritis, you're going to say that acute post-streptococcal glomerulonephritis is the most frequent, followed by non-infectious causes, like I had shown you on the previous slide. Okay, followed by miscellaneous causes like irradiation. Okay, so acute post-streptococcal glomerulonephritis after exposure to certain strains of group A beta hemolytic streptococci that are of nephrogenic strain. For example, a skin infection, that is a streptococci M types 2, 49, 55, 57, 60, and throat infection, that is the M types 1, 3, 4, 12, 25, 18. At least keep in mind at least 3 of the strains. Okay, they may occur as a sporadic a patient that sporadically appears, and you find that the patient has acute PSGN, or it might be an epidemic. Okay, and it is usually a disease of children, but it's not to say that we don't see cases of post-streptococcus glomerulonephritis in adults as well. It is not frequent, but we do see. Features are typically a cola type of color of urine, or what we call smoky urine. There will be microscopic hematuria, if not frank hematuria. Sometimes, because of circulatory congestion, the patients may present with a pulmonary edema, or they may present with encephalopathy due to hypertension. Okay. You have to ask for history of glomerular disease, especially in adults, because it's more common amongst the children. So when it happens to adults, we look for non, what do you call it? We look for non infectious causes first, rather than just, and that too, infectious causes are more frequent in children rather than in adults. Okay, so as for history of any renal disease in the family, that is very frequently seen in something that we call Alport syndrome. Okay, medications that have been taken by the patient that can damage the kidneys in the form of NSAIDs, penicillamine, gold, mercury. Okay, in some skin lightening creams especially, and recent throat infections. Yes, you have to rule out, or a recent skin infection. Okay, any rashes that you might find, like in polyangiitis granulomatosis, like in Wegener's granulomatosis, IgA nephropathy like symptoms. So we will go into IgA nephropathy. That's a completely different topic. I will go look into it, but for the time being, I think we'll stick to just remembering the name IgA nephropathy. But you guys would have an idea because it's the second time these classes are taken. So anyhow. And then in certain malignancies and certain other infectious diseases, viral infectious diseases, you may have presentation with the presentation with acute glomerulonephritis, and then it's tracked back to a systemic disease, or when a person is known to have this particular systemic disease, you will get it during the course of treatment, or during the patient's treatment course. You will have a diagnosis of a glomerular disease, okay, like a cancer, solid tumors, Hodgkin's lymphoma, minimal change disease, non-Hodgkin's lymphoma will present with a mesangial-proliferative glomerulonephritis. Okay, general workup in glomerular disease is on clinical examination. You want to look for pallor. Why? If the hematuria is major, or excessive, you may find pallor. One thing. Second thing, if it is an underlying chronic inflammatory disease, you may have anemia. Third, there will be some dilutional anemia as well because of the fluid overload. So you may have anemia because of that as well. So you may find that there is pallor. You will have pitting pedal edema because there is a lot of fluid and salt retention. So you're going to have subcutaneous edema. Most of the times in renal disease, the patients manifest with subcutaneous edema around the periorbital regions first, followed by the feet, then the rest of the skin. So sometimes you can just find that the patient has anasarca. I've told you this before. Anasarca is the accumulation or third spacing of fluid into subcutaneous tissue or any other body cavities. That's more than two, not just two, it's more than two. So pedal edema and periorbital edema does not make anasarca. Pedal edema, periorbital edema, and maybe an ascites or a pleural effusion you can call that anasarca then. But they do present frequently with anasarca. They have like that dough-like consistency over the abdomen sometimes. It's like the Pillsbury guy. Okay. Then you have pitting pedal edema. You have xanthelasma. Do you know what xanthelasma are? Xanthelasma are nothing but cholesterol deposits in the periorbital region when there is excessive of cholesterol circulating in the serum. Okay, you can have alopecia and you can have facial rashes if it is associated with lupus. They may be associated with clubbing if it's hepatitis-related kidney disease. Purpura can also be there. Endocarditis associated glomerulonephritis may be there. Okay, the patients with vasculitis may have a rash called livedo reticularis that is seen on the shins. On palpation, you may find hepatomegaly and palpable kidneys, if at all, and you may find splenomegaly also, depending on what the underlying cause is. On auscultation, you may find a renal artery bruit, okay, or other bruits anywhere else because of the hyperdynamic circulation, And you may find cardiac lesions if you are considering an endocarditis. You are looking for, these are the things you're looking for. And of course, you will find hypertension in these patients. Okay, when it comes to the labs, again, like I said, urine is so important. You're going to find dysmorphic RBCs, you're going to find RBC casts, you're going to find RBCs themselves sometimes. You're going to have a subnephrotic proteinuria that is less than 3 grams per day, and you're going to have a reduced GFR as based on the creatinine, on the MDRD calculation of the glomerular filtration rate. Skin and throat culture may show a strep growth, may not show a strep growth, but that doesn't mean to say that you don't give antibiotics, because it might be an old strep infection that has presented with this particular manifestation. Many a times our body, even with what is happening with the COVID now, it's not the actual virus and the pneumonia induced by the virus as much as it is the reaction or the inflammatory reaction of the body to the virus as it is that is causing the problem. Overreaction can cause problems in many places, isn't it? So it's more of the overreaction or the over-inflammatory response of the body to the offending agent. Okay, so you may or may not get strep growth, but then you can still treat with antibiotics. There is no harm. Antibodies to extracellular products are that are formed, and that we look into anti-streptolysin, that is the ASO titer, anti-nicotinamide adenosine dinuclease, the ADA factor. Okay, you look for anti-hyaluronidase. Okay, that we do generally do. We look into mostly ADA and ASO. Okay, and then anti-DNase B after pharyngitis. Okay, and these patients, it is mostly pre-renal, so the FNA is low. Okay, and sorry, it's renal, so it's the FNA is low, the fractional excretion of sodium is low. There will be anemia and there will be hypoalbuminemia. Okay, the complement system is something that is also taken into consideration. We look into serum levels of C3, okay, and serum levels of C4 as well. Okay, so the reference level is so. And low complement level associated glomerulonephritis is usually post-infectious glomerulonephritis, mesangiocapillary glomerulonephritis, infective endocarditis, essential mixed cryoglobulinemias, and SLE MPGN. On the other hand, patients who have a normal complement level and still have glomerulonephritis can be seen in IgA nephropathy, can be seen in idiopathic crescentic glomerulonephritis, can be with anti-GBM disease and vasculitides like Henoch-Schönlein purpura, Wegener's granulomatosis, and microscopic polyangiitis. So it's really important when you see a patient with a glomerulonephritis to look at the urine routine, to look at the cultures that may grow an infection that may have caused this problem, and also the complement levels that will tell us whether it is a normal complement level or low complement level. This is an extremely important table. You should know this. Okay. Other tests that we can use are, like I said, ASO titers, okay, triglyceride levels, hepatitis B, hepatitis C serologies, ANCA, okay, if you are suspecting a autoimmune disorder as such, see ANCA, okay, MP ANCA, okay. Okay, so this looks better when you put it up on a slide, but then if you Google different patterns of urine, you are going to find what possible diagnosis can be. Okay, urine is the liquid biopsy of the kidney. That's literally gold. Okay, now you can have 3 different patterns of the glomerulonephritis. You can have a focal nephritic, you can have a diffuse nephritic, and you can have a nephrotic syndrome, nephrotic approach or occurrence of the illness. Okay, focal nephritic patterns associated with the inflammatory response to less than half of the glomeruli in the light microscope. Red cells often dysmorphic. Occasional red cell cast and mild proteinuria may be there. In patients who have diffuse nephritic, damage to all or almost all of the glomeruli, similar to focal disease, but may also have heavy proteinuria, even nephrotic range, edema, hypertension, and our renal insufficiency. That's a full house urinary sediment. Red cells, white cells, red cell cast, and white cell cast, hyaline cast may be there. Okay, that is what we call a full house urinary protein cast. Urinary findings, where you have all kinds of casts. When you make a diagnosis of glomerulonephritis, you can. Okay, red cell casts are most commonly seen in glomerulonephritis and vasculitis. White cell casts is usually seen in acute interstitial nephritis, which we'll discuss about next week. And you might see fatty casts in nephrotic syndrome, minimal change disease, and muddy brown casts in acute tubular necrosis. These are the other things that you may find in the urine routine. You can have an acid-based urine when you have the calcium oxalates crystals that you can see, or uric acid crystals, and all these fancy kind of designs, like they look like earrings, most of them to me. But the pathology guys would know better. In alkaline urines, you will find mostly calcium carbonate crystals, ammonium urate crystals, and then of course you have these strands and other cells. These are what you call, okay, hold on, let me see if I can do this. Oh, I can. I've forgotten about this. So these are the WBC casts, and this is the granular cast, and these are the RBC casts that you can actually see. And it's very interesting. It's not interesting, of course, unless you're really into pathology. But then it's very simple for us to make a diagnosis. It's not rocket science to make a diagnosis of acute glomerulonephritis and what it possibly could be due to. Okay, so we look into doing a biopsy only in certain patients. We don't biopsy all our patients with acute glomerulonephritis. So we start off the treatment, which is common to most of the acute GN, and we try to make sure that it is common for all the treatment, and it is, we try to treat without doing a biopsy. We try to be as what do we call it, as as non-invasive as possible. So we do avoid a renal biopsy, but then if there is a rapidly progressive glomerulonephritis for which we don't know the cause, or if we are suspecting a systemic disease very strongly and we don't know the cause, then yes, I think it's extremely important to do a renal biopsy. Okay. If a nephritic range proteinuria turns into a nephrotic range proteinuria, also we do want to give a consideration for that. Okay. So this is a photograph that shows the enlargement of the glomerular tuft and a marked decrease in the urinary space and hypercellularity. Okay. This is a starry sky appearance that you may see with the granular deposits of IgG in a starry sky appearance. This is a what do we call it? Immunofluorescence microscope. Okay. Differential diagnosis could be a previous history of anaphylactoid purpura nephritis. You don't worry about that. That sounds complicated. Try to remember that it could be a chronic glomerulonephritis in whom there has been an acute exacerbation. Remember that. Okay. It can be an idiopathic hematuria. It can be a familial nephritis. Okay. Post-infectious glomerulonephritis must be differentiated from IgA nephritis, MPGN, lupus nephritis, glomerulonephritis of chronic infection, vasculitis, and non-glomerular disease. TTP, hemolytic uremic syndrome, arthromembolic diseases, acute hypersensitivity interstitial nephritis also may be there. Treatment, anti-streptococcal drugs to patients, okay, edema, diuretics, salt restriction, all of these are very, very important. Antihypertensives for the hypertension. Recovery in 2 weeks in 95% of the patients, and bad prognosis will be dictated by a person who has a late age of onset of the glomerulonephritis. If it's a sporadic disease, if there is massive proteinuria, see, the patient can have initial nephritic range proteinuria and then eventually develop a nephrotic range proteinuria. That always tells us that the disease is progressing and it does not have a good prognosis. If, in spite of the treatment of the glomerulonephritis, if the blood pressure does not come down, and if you have crescents in the light microscope. Okay. Complications of patients who have glomerulonephritis, they usually go in, only 0.5 to 2% of the patients go in for a full-fledged renal failure. Okay, most of them recover and do well. They will always be at risk of renal decompensation, but then it need not be in every case. Abnormal urine analysis may persist for years. That's microhematuria may exist for years. There may be a marked decline in the GFR in only a few cases, mostly rare. Acutely, when the patient presents, the patient may present with an acute pulmonary edema or hypertension. Generalized anasarca hypoalbuminemia may develop. Okay, and chronic renal failure may occur. Nephrotic syndrome may also occur. Okay, I think I'm going to stop there because I know I'm going to lose most of you. So just remind me that this is where I reached rapidly progressive glomerulonephritis. There's another maybe 30 slides to go. So thank you guys, and I will catch you guys later.